think here we should really follow Willie Sutton's rule, follow the money, because there are 2.3 or $2.8 trillion spent on healthcare. It's consumed by 75% of that money is consumed by the patients that have one or more chronic disease, a handful of chronic diseases: diabetes, hypertension, ischemic heart disease, heart failure. That accounts for 81% of hospital admissions, for 91% of all drugs prescribed, and 76% of all doctor's visits.
The hospital is looking at three different buckets. One, it is looking at analytics of data, and the analytics of data is looking at it from the retroactive data, proactive data, and big data management. So retroactive, they want to basically get caught up and understand what has happened. They're looking to have future predictive aspects built in. And we all know that population health, big data management is going to be critical for us to make predictions going forward. The second bucket that they're focusing on is risk management and mitigation, and empowering the patient and enrolling the patient in working with them to ensure that happens. That's a given. It has to be a team approach, and some of my fellow panelists did mention that we have to get the patient more involved. But we all know that you send your 80-year-old grandmother home, she falls, she comes back, and then the costs skyrockets, and there's a spiral to that. So just making sure that those facets are taken care of. And then the third thing is, and that's a given, we're seeing that is the whole consumerization of IT. So the trend of bring your own device, and is going to be, we'll see more of that.
The move to EMR and EHR, I think is certainly something that the entire venture industry is looking to. I think it's happening at a slower pace than people predicted 10 years ago. But the benefits, both from a cost and efficiency perspective, are pretty self-evident. So what happened to healthcare financing in 2012? So in 2012, 134 digital health companies raised at least $2 million or more. That's a pretty impressive number if you think about it, and that it's been going up actually, just pointing to the kind of trend that I think we're all going to be speaking to, and what we're all kind of excited about on the panel tonight. Within that, the kind of biggest buckets were personal health tools and health tracking, consumer engagement, there were EMRs, EHRs, and finally there was hospital administration, kind of enabling that to be more efficient.
With the High-Tech Act first, and then the ACA, the healthcare reform, there are a number of programs that CMS, the Center for Medicare and Medicaid Services, has instituted in order to hold hospitals more accountable. There's more reporting on the kinds of what's called meaningful use, the kinds of uses in hospitals of electronic medical records. There's something called value-based purchasing, where Medicare reimbursement now depends on how well you're doing in your hospital, and hospitals have to report on a fairly large number of measures on how well they're doing, whether it's faults in the hospitals, infections acquired in the hospitals, readmissions, and so on. For readmissions specifically, there is a program where, again, for readmission within 30 days, there are penalties. Or not reimbursement based on that.
At different phases, you're seeing a multi-year, multi-phase program put together in different silos, but at the end of the day, the idea would be to cross function and utilize it in a meaningful way for a positive outcome.
The consumerization of healthcare actually is kind of an orthogonal solution to this problem, right? In a way, because as I mentioned earlier, things like this whole quantified self movement are allowing consumers, both the individual as well as consumers en masse, to upload their health data, right? Whether it's measured or whether that they've inputted from their medical history or charts into the cloud, and that's leading to sort of all sorts of interesting scenarios where now you can look at that data as a third party, as a commercial entity, or as a medical entity, and figure out interesting patterns derived from it. And so that's another way to circumvent the fact that yes, the data lives within all these different silos within the traditional hospital IT infrastructure, but yet this consumerization of healthcare is allowing the data to then be made available in more of a democratized fashion and could be another way for innovative companies to tap into all the types of things that you can do it, whether it's, as Royce mentioned, predictive analytics, or whether it's kind of, as you mentioned, then kind of inferences about national trends versus regional trends. I think all of these things should be possible increasingly over time as both of these trends get traction.
Basically, the take-home message is, to me, is any application, any product that improves patient access to their doctor and improves access within the healthcare system to other specialists is going to succeed. And but a lot of that is also retraining the doctor.
It's a mindset. That's what
the technology is
yes.
actually fairly straightforward for
Right.
video conferencing and teleconsultation.
I think we need to be mindful of the fact that there are socio-political, economic forces at play. So one obviously is the alignment of interest. And in the case of Kaiser, you're absolutely right. The cost containment can take place because all the systems are saying the same thing, right? And unless you have that, no matter how many data you have and how many databases you have and how many systems you have, unless you have a fundamental alignment of interest, the system is not going to work because somebody is going to find a way for it to not work. And if everybody is paid for the system to work, then it is automatically has a higher likelihood for it to happen.